A 61-year-old retired teacher sits across from a psychiatrist and says something clinicians hear more often than you'd expect. I spent my whole life thinking I was just not as good as everyone else at being a person. She raised 3 kids, taught middle school for 32 years, and was, by every external measure, successful. She was diagnosed with ADHD 8 months earlier, after her grandson was diagnosed, and she recognized, with a kind of quiet devastation, her own childhood in his evaluation notes. 8 months earlier, at 61. This is not a rare story. It's an extremely common one. And today we're going to explain, clinically and honestly, why this happens so often. Let's start with a number worth knowing. Research consistently shows that a large proportion of adults with ADHD, some studies suggest a majority, were never diagnosed in childhood, despite the DSM-5-TR requiring that symptoms have been present before age 12. That's not a contradiction. It means the symptoms were there. Nobody connected the dots at the time. So why not? Let's go through this systematically, because there isn't one single cause. There are several, and they compound each other. Reason 1. The historical diagnostic picture was built almost entirely around hyperactive young boys. When ADHD entered clinical awareness broadly in the latter half of the 20th century, the research population that shaped early diagnostic thinking was disproportionately young, hyperactive, disruptive boys, kids who were, quite literally, hard to ignore in a classroom. That created a lasting cultural image. ADHD equals a boy who can't sit still and gets sent to the principal's office. Anyone who didn't match that picture, quiet kids, girls, high-achieving kids, kids who internalized rather than externalized their symptoms, simply didn't register on most teachers' or parents' radar as having ADHD, even when the same underlying neurodevelopmental pattern was fully present. Reason 2. Sex differences in presentation. This is one of the most well-documented gaps in ADHD recognition. Girls and women are more likely, on average, to present with the inattentive presentation we discussed in Episode 1, the quiet, internal kind, without the overt hyperactivity that tends to trigger adult concern. A girl who's spacey, who daydreams, who's a little disorganized but gets her homework done through sheer effort and anxiety, doesn't disrupt a classroom. She gets called a bit of a dreamer in a report card comment, not referred for evaluation. Research has shown that boys are diagnosed with ADHD at meaningfully higher rates than girls in childhood, and a substantial part of that gap appears to reflect under-identification of girls rather than a true difference in prevalence. The gap narrows considerably in adulthood as more women get diagnosed later in life, which is itself telling. Reason 3. Intelligence and compensation. This one surprises people. Highly intelligent individuals with ADHD often develop elaborate, exhausting compensatory strategies, extra hours of studying, perfectionistic double-checking, leveraging strong verbal skills to talk their way through gaps in preparation, that mask underlying executive function difficulties well enough to get by, sometimes for years. The compensation works right up until the environment changes and demands outstrip what the compensation strategies can cover: a promotion with more autonomy and less external structure, a first semester of graduate school without the built-in structure of high school, having a child and losing all your former solo-focus time. Clinicians call this pattern coasting, and when it collapses, it often collapses hard, sometimes triggering the first serious depressive or anxious episode of someone's life. This is a genuinely important clinical pattern. A person can be objectively gifted and still have significant, real ADHD-related impairment. The two are not mutually exclusive, and giftedness can actually delay recognition rather than rule anything out. Reason 4. Masking and camouflaging, particularly in women. Beyond simple compensation, many women in particular describe a more active process of masking, consciously monitoring and adjusting their behavior to appear more organized, attentive, or composed than they internally feel, often to avoid social judgment. This takes enormous cognitive energy, and it's part of why so many women with ADHD describe chronic exhaustion and burnout that seems disproportionate to their actual workload. They're running two systems simultaneously: the task itself and the performance of appearing neurotypical while doing it. Reason 5. Comorbidity confusion. This one connects directly back to episode 2. When a person's primary presenting complaint is anxiety, depression, or burnout, which is extremely common since these conditions frequently co-occur with ADHD, clinicians may treat the more visible, more acutely distressing condition first, which is often clinically appropriate as an immediate step. But the underlying ADHD can remain unaddressed and unrecognized for years if nobody circles back to ask about a broader developmental history. We'll spend all of episode 4 on the anxiety overlap specifically, but it's worth flagging here as a major contributor to diagnostic delay. Reason 6. Access and systemic factors. Not everyone has had equal access to pediatric evaluation, and this isn't evenly distributed. Family income, insurance access, healthcare literacy, and, well documented in the research, racial and ethnic disparities have all been shown to affect who gets referred for ADHD evaluation as a child in the first place. Some children who showed clear symptoms simply never had access to an evaluation at all. Let's ground this in 2 full examples. First example, Sarah, 38, an attorney. Brilliant academic record, valedictorian, top of her law school class. She describes her entire education as controlled chaos held together by panic and caffeine. Pulling all-nighters not because she procrastinated out of laziness, but because starting tasks early, without an urgent deadline creating adrenaline, felt nearly impossible for her brain to do. This is actually a recognized pattern. Some clinicians describe it informally as needing an urgency signal to activate task initiation, tied to how dopamine-related motivation circuits function differently in ADHD. Sarah's compensation strategy: extreme deadline pressure as a substitute for internally generated motivation, worked all the way through law school. It stopped working when she became a partner track associate, juggling 4 ongoing cases simultaneously with no single acute deadline to organize her focus around. Her collapse looked like burnout. Underneath the burnout was undiagnosed ADHD that had been present and compensated for since elementary school. Second example, James, 49, a contractor, diagnosed only after his son's diagnosis prompted a family conversation. James grew up in a household and era where ADHD-like behavior in boys was interpreted as just being a boy, restless, a little wild, not academically inclined but good with his hands. Nobody in his working-class community in the 1980s was getting psychiatric evaluations for energetic kids. He built a successful contracting business, which, interestingly, is a career that plays remarkably well to certain ADHD strengths: physical activity, variety, hands-on problem solving, and relatively low demands for sitting still doing paperwork. But the business's actual paperwork, invoicing, scheduling, licensing renewals, was chronically, stressfully behind. And James assumed this was just a personal weakness rather than a recognizable, well-documented ADHD pattern. Strength in dynamic, hands-on tasks paired with genuine difficulty with sustained administrative tasks. Now, clinical perspective. When clinicians take a history from an adult who suspects ADHD, we are specifically trained to ask about childhood in ways that go beyond, "Were you ever diagnosed?" We ask about report cards. Did teachers frequently comment on daydreaming, not working to potential careless mistakes despite clear intelligence? We ask about the structure of the household growing up. Highly structured households with a lot of external scaffolding can mask symptoms that would otherwise be obvious. We ask about hobbies and hyperfocus. Many undiagnosed adults describe intense childhood interests they could focus on for hours, which actually supports an ADHD picture rather than contradicting it, since it shows the attention regulation issue is about consistency and interest dependence, not a uniform inability to focus. This detailed retrospective history taking is exactly why a proper evaluation, which we're covering in depth in episode 5, takes real time and can't be replaced by a 10-question form. Let's address the misconceptions. Misconception 1. If I wasn't diagnosed as a kid, I can't have ADHD now. Untrue, and directly contradicted by the clinical literature. The DSM-5-TR requires that symptoms were present before age 12, not that they were diagnosed before age 12. Clinicians routinely diagnose adults using a careful retrospective developmental history, precisely because so many people, for all the reasons we just covered, were missed in childhood. Misconception 2. ADHD is being overdiagnosed now because so many adults are suddenly getting diagnosed. The picture is more nuanced than a simple increase implies. A rise in adult diagnoses partly reflects genuine improved recognition of long underdiagnosed groups, particularly women and high-functioning individuals, correcting decades of underidentification. Not simply a trend or a fad. That said, thorough differential diagnosis, which we'll detail in episode 5, remains essential in every single case to distinguish genuine ADHD from other explanations, and responsible clinicians take that seriously rather than diagnosing reflexively. Misconception 3. If someone did well in school, they can't have had ADHD. Academic or professional success, especially in gifted or highly compensating individuals, does not rule out ADHD. It often just means the compensation strategies were unusually effective for unusually long until they weren't. So, practical takeaways. Late diagnosis is common, not rare, and it happens for identifiable, well-documented reasons. Historical bias toward hyperactive boys in diagnostic criteria and cultural awareness, sex-based differences in presentation, compensation by intelligent or high-functioning individuals, masking behaviors particularly common in women, comorbid conditions overshadowing the underlying pattern, and unequal access to evaluation in childhood. None of these reasons reflect a flaw in the person who was missed. They reflect limitations in how the condition was historically recognized, And there are real costs to late diagnosis. Years of unexplained struggle, self-esteem damage from being told to just try harder, and sometimes secondary conditions like anxiety or depression that develop from grappling with unexplained lifelong difficulty. Late diagnosis is not a life sentence, though. Many adults describe genuine relief and meaningful improvement in functioning even after diagnosis at 40, 50, or 60. Here's the question this naturally raises, and it's one of the most clinically important questions in this entire field. If ADHD symptoms overlap so heavily with other conditions, and if late diagnosis is this common precisely because those other conditions get identified first, how does a clinician actually tell them apart? Specifically, how do you tell the difference between ADHD and the condition it gets confused with more than any other?